Hi, my name is Naya North. I did my engineering honors capstone project on a need assessment I conducted at Capstone Teaching Hospital in Kumasi, Ghana. I got involved with this project through the Global Health Design Initiative, which offers academic experiences and internships every year. I was inspired by my own experience with illness, and I thought global health would be a good field to get into to give back, and it was really rewarding. Something that was really difficult for me throughout this experience was dealing with anxiety and talking to people I didn't really know in an unfamiliar environment. But in the end, everyone was really welcoming, and I made some really amazing friends. So to start, hospitals in low and middle income countries, or LMICs, face unique challenges. The majority of health technology is designed for high resource settings, and cost, human resources, energy supply, distribution, and maintenance are all barriers to obtaining these technologies. The picture on the right is a graveyard of primarily donated equipment that couldn't be maintained because replacement parts weren't obtainable, either because they were too expensive or because the medical equipment brokers weren't in country. Specifically at the Accident and Emergency Department at Capstone Teaching Hospital, or CAF, in Ghana, the hospital faces problems with implementing commercialized devices due to cost, maintenance, and replacement parts. That graveyard picture was taken at CAF. The department also faces problems with overcrowding, with a large patient-to-provider ratio, and the hospital operates above capacity most of the time, with 1 to 10 extra patients in each ward. The purpose of this project was to identify and define unmet clinical needs, learn about the broader context in the Accident and Emergency, or A&E department at CAF, and inform student senior design projects in the Mechanical Engineering department that aim to develop preliminary concepts to potentially address some of the more pressing needs. The objectives were to foster collaboration among the University of Michigan and CAF, and to identify and refine these needs in the A&E department through general observations, interviews, and collaboration with stakeholders. We also wanted to develop and apply a filtration rubric to select top need statements for the senior design course, and determine user requirements and design specifications through focused interviews, observations, and literature reviews. And finally, we wanted to elicit user feedback through discussion of benchmark solutions and preliminary design concepts to better inform a CAF-appropriate solution. This was all done using design ethnography methods, which you might be wondering, what is design ethnography? Ethnography is rooted in anthropology. It's defined as the method used to describe a group, community, or culture. Design ethnography is a method that uses this principle to understand the context of a need and how a new product may fit into the lives of people in a community. We follow this process of understanding, exploring, and materializing in a non-linear and iterative method. For this experience, there's a heavy emphasis on the understanding, where we were immersed in the environment to help us understand what our stakeholders experience. We observed stakeholders to understand what people do, and we interviewed people to understand their perspective and understand what they say they do, which is often different from what they actually do, only because people aren't used to analyzing their everyday tasks. Design ethnography is important because it allows us to gain insight into the user's environment, reduce the effect of personal thoughts, opinions, and biases, and better understand and design for the context of use, such things like environmental factors, or who needs to be involved in using and maintaining the product, understanding how the product will actually be used, and it also allows us to generate a path to developing a solution with user collaboration. And it also helps us to develop a more holistic understanding of external or downstream effects of the solution, where we can consider who else would be affected by the implementation of the solution. And all of these things help to ensure that the solution will be accepted into the community, used as intended, and will continue to be used for a long time. So for our methods, 3 University of Michigan students, including myself, participated in the Global Health Design Initiative program in the Accident and Emergency Department in Kumasi, Ghana. I was there for 5 weeks, and the other 2 people I was working with were there for 7 weeks. We were all there from May to June 2019. And while there, we conducted ethnographic research in 3 stages. And although we did it in 3 stages, the elements of each stage were kind of implemented throughout the experience due to the nonlinear nature of the design work. So for stage 1, we rotated through all 3 wards of the accident and emergency department. Red, which is for the most critical patients. Orange, which is for stable patients that are still needing close to immediate care. And yellow, which is for the least critical patients. We also spent some time in triage, which is where patients go initially and are sent to each ward based on their initial assessment. While rotating through the hospital, we observed staff, primarily doctors and nurses, and conducted informal interviews. This was part of the understanding phase of design ethnography. At the end of each day, we met to compile all of the information we had gathered in a large spreadsheet. We analyzed trends in the qualitative data and constructed need statements based on these trends. We then prepared interview questions for the next day based on missing or incomplete data for each need statement. We continued to generate need statements throughout the experience, but these first few weeks were heavily focused on generating need statements and were where the bulk of the need statements were generated. And throughout the course of the experience, a total of 62 need statements were generated. During stage 2 of the experience, we developed and applied 6 filters to select 2 needs to focus on for our senior design projects from the 62 original needs. During this time, we also conducted more observations and focused interviews to better understand needs that were flagged as being more pressing based on previous observations, interviews, and feedback from stakeholders. For the first filter, the needs were classified as being related to health technologies, training and education, and hospital operations. The health technologies meant that the need could likely be solved by a health technology. Training and education meant that the need could be solved by a training or education solution like a simulator. And hospital operations were just what it sounds like, operations throughout the hospital. Those needs, the hospital operations, were eliminated because they did not fit into the scope of a mechanical engineering design course. For the second filter, we evaluated whether or not each need had a clear trivial solution. A trivial solution was defined as a need that had an obvious and easily implementable solution. For example, we had a need that was a way to provide adequate protection to providers' eyes to reduce exposure to patient fluids. And that need could be solved with face shields, which is a relatively cheap to produce and commonly used tool like the one shown in the picture there. To identify which needs were considered trivial, each of us rated the need a 1, 2, or 3. A 1 meant that we could immediately think of a solution to the need. 3 meaning that the need could be addressed by mostly non-trivial solutions, and a 2 being somewhere between the two. The average between all 3 of us was taken, and any score less than 1, any need with a score less than 1 was eliminated. For the third filter, the remaining needs were sent to our program mentor to evaluate whether or not each need was in the scope of ME 450, which is our mechanical engineering senior design course, and any need that was not in the scope was eliminated. For the next filter, we eliminated, revised, and combined needs based on feedback we had received from our program advisor and sponsor, and also further information we had gathered from observations and interviews throughout this process. And we were left with 13 needs, which we took to a number of healthcare providers within CAF, and we asked each provider to rate the need a 1, 3, or 5. A 1 meant that the need did not require an immediate solution at CAF. A 3 meant that it would be nice to have a solution for the need at CAF, and 5 meant that the need was one of CAF's largest problems and the solution was critical. Any need scoring an average of 3 or higher moved on to the next filter. So these were our final 6 needs. I won't get into the specifics of each of these in this presentation, but there's a full report, and if anyone is interested, they can contact me. The final filter to obtain these 2 needs from the previously listed 6 was just team interest. So essentially we picked the needs we wanted to work on from that list. And these final 2 needs were, there's a need to control the intravenous or IV drip rate to patients requiring IV medication to reduce time required for nurses to administer IV medications. And there's a need to completely restrict motion of lower limbs with femoral shaft fracture for up to 24 hours to prevent further injury. From here, that brings us into stage 3 of the experience. In this stage, we began eliciting user requirements and design specifications for the final 2 selected needs I just listed. To do this, we conducted more interviews and observations. We also led focus groups with nurses. In these interviews and focus groups, we were looking for directly medical relevant requirements, which would be like safety related things, like how to reduce the risk of pressure sores with traction devices, or what the specific increments of IV flow rate should be. We also showed healthcare providers pictures of benchmark solutions and how they worked. In doing this, we asked for their feedback on what they liked and disliked with each of the solutions, so we could get an idea of what things are good attributes and which things we should avoid with our solution. We also conducted a context assessment so that we were looking at the things outlined in the figure on the right. We used this model to understand the frame of reference for user-product interaction and how users may understand the product. We analyzed the users, which were primarily nurses, by performing more observations and talking to them about their beliefs, lifestyle, and cultural characteristics. In order to obtain an understanding of the project user interactions and usability, we observed the way nurses interacted with existing equipment and asked nurses and maintenance staff what things around the hospital were easy or difficult to use and why. We also asked the maintenance staff what things they fix or replace often and what things they liked or disliked about existing products. We considered additional technical factors related to the supply chain by talking to the staff in the storerooms and the procurement office in order to understand how products are obtained and distributed throughout the hospital. We also wanted to understand problems in the supply chain with procuring and maintaining equipment, especially when replacement parts are required. This process also provided insight into the healthcare system and bureaucratic structures involved in care, including health insurance and barriers to care due to affordability. The environment was closely observed for factors such as temperature, humidity, access to electricity, and department resources. So finally, as I said before, we generated 62 need statements over the course of this experience. These were broken up into 10 categories. There were 10 needs in the hospital processes category, which are related to hospital logistics or the way a process is performed, where the process could possibly be optimized. 9 needs were assigned to the vital treatment category, which were related to providing vital or timely care to keep patients alive and or stay healthy after treatment. 8 needs were related to provider and patient protection, which are needs about keeping all healthcare providers and patients safe from communicable diseases and preventable infections. 8 needs were in the patient tracking category, which were needs related to keeping track of patient documentation and intervention. 8 needs were in the patient care category, which were related to meeting non-essential or non-medical patient needs. 7 needs were in the patient transfer or transport category, which refers to healthcare worker and patient needs associated with transferring or transporting patients. 4 needs were in the obstructions to care category, which refers to needs related to physical obstructions to hospital processes or operations. And 4 needs were in the procurement and maintenance category, which were related to obtaining and maintaining equipment and technology. 3 needs were in the monitoring category, which refers to monitoring vital signs. And finally, just 1 need was related to patient family care. This need was about patients' families needing to sleep outside on the CAF campus or in the parking lot outside of the A&E department because they had nowhere else to go. As I talked about earlier, we had come across the concept of trivial needs during our filtering process. So these were the 7 needs identified as trivial needs. They were eliminated for our purposes because something that is easily solved does not fit well into the work required for a senior design course, but they should not be disregarded as there could be potentially quick fix solutions that could assist providers and improve productivity. So to conclude, hospitals in low and middle income countries face these unique challenges. Cost distribution and energy supply are just examples. To design for these settings, we need to understand the broader context, and we can do this using design ethnography. So in this study, we identified 62 unmet needs from 10 categories and picked 2 to focus on for our senior design projects. Thanks for listening.